I will introduce the combination of two tests. I will first introduce the concepts of conditional dependence. When one subject receives two imperfect tests, the test results may not be independent. For example, if a patient has a positive or negative test result in one test, the likelihood of having the same test result in another test may be increased. Ignoring conditional dependence between tests would exaggerate the incremental value of the new test. The conditional dependence between tests can be modeled by the unmeasured or unobserved covariances, conditional on disease status. Let S1 and S2 denote the sensitivities for test 1 and test 2, respectively. For the disease-positive group, the probability of positive results in both tests is increased by an amount, covariance S, when two tests are correlated, compared with the conditional independent case. One can calculate that the probability of one positive and one negative result is decreased by covariance S, and the probability of negative results in both tests is increased by covariance S. The correlation for the disease-negative group, covariance C, can be derived in the same way. The expressions for these probabilities are given in this table. Let 0 be the minimal value for covariance S and covariance C, which indicates that two tests are conditionally independent. Theoretically, the lower bounds of covariance S and covariance C are negative values. A negative covariance S means that a person with a positive result in test 1 has a decreased likelihood of a positive result in test 2. A negative covariance S and covariance C do not often occur in clinical practice, so we can assume the lower bounds are 0 in the economic modeling. For the disease-positive group, it also needs to satisfy the condition that the probability of positive in both tests cannot be greater than the sensitivity in either test. Then, we can derive the upper bound of covariance S. There are two commonly used criteria to define a composite decision rule for two tests. The conjunctive positivity criterion. Composite test result is positive only if both tests are positive. We can call it as AND rule. Or the disjunctive positivity criterion. Composite test result is positive when either test is positive. We can call it as OR rule. If we apply the conjunctive positivity criterion, the composite test gains specificity but loses sensitivity compared with either test alone, whereas if we apply the disjunctive positivity criterion, the composite test gains sensitivity but loses specificity. However, the composite test strategy may have advantages in specific situations. For example, when high sensitivity is preferred for maximizing case detection, or when a high positive predictive value is preferred to avoid harm from unnecessary treatment. Now, we discuss how to quantify conditional dependence in the modeling. When a perfect reference standard test is available, it may be possible to directly estimate conditional dependence within a meta-analysis of test accuracy. If there is the absence of a perfect reference standard, we can use a latent class meta-analysis model for test accuracy. In addition to estimating the sensitivity and specificity of the test under evaluation. The index test. This model can also be used to obtain estimates of the sensitivity and specificity of the reference tests, covariance parameters, covariance S and covariance C, and the true disease prevalence. When sensitivity and specificity estimates of two tests are obtained from separate studies, the covariance cannot be determined. However, for various reasons, we may expect that the two tests are not independent. In this condition, researchers can assign the covariance and evaluate the impact of conditional dependence in a sensitivity analysis. I will use an example to illustrate the concepts introduced above. tissue biopsy was considered as a perfect test for determining T790M status for patients with lung cancer in some publications. However, tissue biopsy is an imperfect reference standard. The tissue biopsies test takes a sample from tumor cells, while the T790M mutation may not be present in all sections of the tumor. We used a decision analytic model to compare plasma DNA testing plus tissue biopsy versus plasma DNA testing alone. We used the same model for 3 scenarios. 1. Assuming perfect diagnostic accuracy, 100% sensitivity and specificity of tissue biopsy. 2. Tissue biopsy is not error-free and assumes conditional independence between biopsy and ctDNA. And 3. Incorporating dependence between tissue biopsy and plasma DNA tests. 3 scenarios have the same model structure, but different diagnostic accuracy estimates. This slide shows the results of the economic evaluation. Although all 3 scenarios showed that plasma DNA plus tissue biopsy testing resulted in increased instances of correct treatment decisions, the magnitude of benefits are different. Scenario 3 had the smallest incremental health benefits and highest ISA. We concluded that after accounting for the imperfect nature of both tests and the conditional dependence between tests, the potential health benefits from the additional test were reduced. This may better reflect the real-world application of the tests with improved accuracy.